So today I'll be talking about anti-epileptic therapy in women with epilepsy. I don't have any disclosures relevant to the talk. So the learning objectives today will be talking about the effects of neurosteroid hormones on neuronal excitability and seizures. We'll be talking about catamenial epilepsy briefly, which is basically clustering of seizures around the menstrual period, anti-epileptic drug therapy during pregnancy, which is going to be the main focus of this talk, and also some considerations during perimenopausal and menopausal period. So effects of hormones on neuronal excitability. Estrogen is an excitatory proconvulsant molecule. Now, this could be secondary to decreasing the conduction of chloride through GABA receptors, inhibition of GABA synthesis, increased neuronal response to glutamate. There are certain forms of estrogen that have shown to be anticonvulsant, but majority of the molecules are proconvulsant. On the other hand, sorry about that. On the other hand, progesterone is anticonvulsant. So this could be due to increased chloride conductance through GABA or promoting neuroinhibition. Allopregnanolone, which is a neuroactive progesterone metabolite, has neuromodulatory effects, which is similar to potent benzos. So here I have a graph here on the left side, which goes through a typical menstrual cycles. As you know, menstrual cycle consists of a follicular phase, an ovulatory phase, a luteal phase, and a menstrual phase. The yellow line here is for estrogen and the dotted blue line is for progesterone. So this is a typical ovulatory cycle. And here we have an anovulatory cycle. As you can see in a typical ovulatory cycle, the estrogen and progesterone levels rise, and then there is a difference in the ratio between the progesterone being higher during the ovulatory phase, the luteal phase, and it is lower for estrogen. And then there's a sudden drop right before the menstrual bleeding. So by far the most common one, of catamenial epilepsy is the perimenstrual, which is thought to be secondary to rapid withdrawal of the progesterone. So as we remember, progesterone is an anticonvulsant. So the rapid withdrawal of that progesterone molecule can result in, seizure clusters. Peri-ovulatory is, due to a rapid, steep increase in estrogen levels prior to ovulation. And during the inadequate luteal phase, there's an increased ratio of estrogen to progesterone, so an increased ratio of proconvulsant to anticonvulsant that leads in increased seizure frequency. So this is a proposed treatment algorithm by Hardin and Pennell and colleagues. So the first thing that we need to determine is what is the level of increased seizure frequency. Level 3 basically means there is 3 times or greater increase in seizure frequency compared to baseline. So, if there is an increase 3 times or more, then progesterone lozenges can be used. So they are being used 200 milligrams 3 times a day, starting from days 14 to 28. Clobazam can also be used for 10 days, beginning at 2 days before the increased seizure frequency is noted. Estazolamide can also be used. However, we have to be careful because it loses its effects after a few days. The most common strategy, I think, is increasing the daily dose of the anti-epileptic medication which the patient is already on. Now, we have to be a little careful with phenytoin in this case because it doesn't follow the normal linear kinetics as other medications. Medroxyprogesterone has also been tried. But the problem with this is that it results in delayed return to baseline fertility in some cases. So now switching gears and moving on to perimenopause and menopause. So, we have to be careful about the estrogen and progesterone ratio. So perimenopause, there is increased seizure frequency, which is thought to be due to the increase in this ratio. And it has been shown that patients with catamenial seizures tend to have more worsening because they are more sensitive to this. In menopause, there is no clear consensus whether there is worsening of seizures. However, in patients with catamenial epilepsy, it has shown to have improvement in menopause. Hormone replacement therapy, the commonly one prescribed, increases the ratio of estrogen and progesterone. So again, that can result in increased seizure frequency, and that has been shown in a dose-dependent manner. And we also, of course, have to pay attention to the bone health, especially patients on traditional enzyme-inducing medications. So monitoring their vitamin D, calcium levels are important. So now let's talk about the effects of anti-epileptic medication on steroid hormones or oral contraceptive pills. So here on the left, I have the list of medications which lower hormone levels, and on the right here, I have a list of medications that do not cause significant effects. Now, as you can see, there's a common theme here. On the left here, these are mainly enzyme inducers, and some of them can have a dose-dependent response. And on the right here, we don't, these are non-inducing agents. A few things that I would like to mention is valproate, even though it does not have a lot of effect on estrogen and progesterone, but actually can cause increase in testosterone levels in women, which can lead to increased incidence of polycystic ovarian syndrome. And lamotrigine is interesting. So, estrogen-containing oral contraceptive pills can actually decrease lamotrigine levels. So something to be mindful of if somebody who is on lamotrigine starts to have increased cluster of seizures or increased seizure frequency, we should always explore the possibility of the use of oral contraceptive pills. And if possible, other forms of contraception should be considered like IUDs, barrier methods, and even medroxyprogesterone at a shorter interval of 10 weeks can also be considered. Now let's talk about pregnancy in women on AEDs. So epilepsy is the most common neurologic disorder requiring daily treatment during pregnancy. And we have to be mindful of increased maternal and fetal risk. We have to be careful about increased risk of seizures and also anti-epileptic medications. And it sort of becomes a balancing act between the teratogenic risk of AEDs and maintaining the maternal seizure control. So let's talk a little bit about the risk of seizures during pregnancy. So generalized tonic-clonic seizures have been reported to cause maternal fetal hypoxia, fetal bradycardia, miscarriages, fetal intracranial hemorrhage, and in some cases, even increased developmental delay based on the frequency of seizures. There are some reports that status epilepticus may cause a high mortality as 30% in the mother and 50% in the infant. Focal seizures, we have less evidence. However, there are reports of prolonged uterine contraction with fetal heart rate deceleration. And as we know that focal unaware or complex partial seizures can cause trauma, which can be detrimental as well. So change in frequency of seizures during pregnancy. So according to 2009 AEDs practice parameter, there is insufficient evidence to determine whether there is change in frequency in women with epilepsy during pregnancy. However, there are reports from Reisinger and colleagues from Emory which show that 38% of their patients actually had increased seizure frequency. And the report from Venescu from Brigham showed that focal seizures actually had a higher rates compared to generalized, and even frontal lobe epilepsy, interestingly, had higher rates of worsening during pregnancy and postpartum period. But what is important here is the seizure frequency prior to pregnancy. So all these studies tend to suggest that if you have a good seizure control prior to pregnancy, in the 9 months or a year prior to pregnancy, the chances that your seizure will be controlled during pregnancy absolutely goes higher. Now let's talk a little bit about the risk of AEDs. So the major risk is major congenital malformations. So MCMs are reported in approximately 1.6 to 2.1% in the general population. The common ones are congenital heart disease, ventral septal defects, cleft lip, cleft palate, neural tube defects, hypospadias, and skeletal deformities. So in the bracket here, I have, the number of days when these defects can develop. And the reason I have them here is I wanted to highlight the point that by the time most women realize that they are pregnant, it's too late to make medication adjustments. So, it's important to plan this, if possible, before pregnancy. So thankfully, we have pregnancy registries, which are available that can guide us, telling us about the prevalence of malformations in women with epilepsy. So here I have listed the common registries. So Europe is the International Registry, North American, UK, Australian, and Kerala as well. So this is the most latest data from the North American Pregnancy Registry looking at the prevalence of major malformation. As you can see here, the rates for lamotrigine, carbamazepine, levetiracetam, and even oxcarbazepine are quite low in the range of 1.9 to 2.9. And valproate is, the rate of 9.3%. So by far quite higher compared to these medications. So this was a comparative study that was published looking at the commonly prescribed anti-epileptic medications from 97 to 2011. This came out from the North American Pregnancy Registry. As you can see here, so they first compared in unexposed groups versus unexposed groups. So they found, as you can see here, valproate carries a relative risk of 9 versus something like lamotrigine, carbamazepine, levetiracetam is much lower, around 1.8 to 2.2. And when they compared the relative risk to lamotrigine, even then, valproate had a relative risk of 5.1. And for something like carbamazepine, it's like 1.5, or phenytoin, and levetiracetam is also much lower. So they also found that the risk of MCM increased with the valproate dose. So the median average daily dose during the first trimester was 1 gram for pregnancies with malformations and 750 milligrams for people with infants without malformations. But there was no trend seen with other AEDs in this particular study, but we'll see in the next slides that there are other studies that suggest that. So the common malformations are hypospadias. By far, valproate is the most common offender. Neural tube defects, again, I would say valproate. Cardiovascular anomalies, most commonly seen with valproate and phenobarb, and also to some extent with phenytoin. And oral clefts are seen most commonly with topiramate, valproate, and phenobarb. So this is the comparative study that came out of the URAP registry, and this was published in 2018, comparing the commonly prescribed AEDs. And as you can see, there's a common theme here, valproate with a prevalence of 10.3% and phenobarb 6.5%. And again, good rates were seen for lamotrigine, carbamazepine, and oxcarbazepine. So the URAP registry data suggested that there is a dose-dependent response not only for valproate, but also for lamotrigine, carbamazepine, and phenobarb. As you can see here, prevalence was less for 325 milligrams for lamotrigine, 700 for carbamazepine, 650 for valproate, and less than 80 milligrams for phenobarb. So let's talk a little bit about polytherapy versus monotherapy. So according to the practice parameter focusing on pregnancy, polytherapy had higher rates of MCMs compared to monotherapy. But I think it's time to reconsider this rule a little bit because not every polytherapy combination is the same. So as you can see here, there are reports that the prevalence of MCM is 9.1% when LTG is combined with valproate, but it's 2.9% when it's used with other AEDs. Similar findings are seen with carbamazepine when combined with valproate was 15%, but 2.5% when used with other AEDs. 1.8% for the combination of Keppra, levetiracetam, and lamotrigine, 6.9% when it was combined with valproate. And the last one here is an interesting finding. It's 9.4% when levetiracetam was combined with carbamazepine. This just highlights that there's still a lot of data that needs to be gathered before we can reliably recommend one particular polytherapy. But I would say lamotrigine, carbamazepine, and levetiracetam when combined together should be a good option if needed. So this is a busy slide, but it just highlights the point that the newer anti-epileptic medications like lacosamide, eslicarbazepine, brivaracetam, and perampanel, there's not a whole lot of data yet. We are limited with case reports, case series, and fewer pregnancies only. These are also confounded by the use of other AEDs. So far we don't have enough data to recommend any of these medications during pregnancy. So if I have to summarize this picture here, it really illustrates it well. So far, based on the data that we have, the teratogenic risk profiles for lamotrigine and levetiracetam are the least, followed by carbamazepine, oxcarbazepine, phenytoin, phenobarb, and topiramate, and then finally, the most risk is seen with valproate acid. So let's talk a little bit about perinatal and neonatal combination. So there is report of increased small for gestational age up to 2 times in women with epilepsy on seizure medications. And, there's also, it's a possible increased risk of perinatal death and decreased APGAR score at 1 minute. There is insufficient evidence to suggest increased hemorrhagic complications. And there is insufficient evidence to, support or refute vitamin K supplementation. The risk has been for small for gestational age has been shown more commonly with topiramate, zonisamide, valproate, and carbamazepine. Increased perinatal and neonatal complications are not only just because of AEDs, they can also be because of the seizures themselves. So there are reports where patients who had increased seizure frequency during pregnancy had more rates of SGA compared to those who were well controlled. So let's talk about the neurodevelopmental effects of anti-epileptic drugs. So this is by far the most significant study, the NEAT study, which was a prospective observational multi-center study, which enrolled patients with 4 commonly prescribed drugs, that is carbamazepine, lamotrigine, phenytoin, and valproate. As you can see, the primary outcome was IQ at 6 years of age. And as you can see, there is a significant approximately 7 to 10 point difference when you compare with valproate, and that was true for the patients who completed 6 years in the study as well. There was a dose-dependent response as illustrated by this graph here, that as the valproate dose increased, there was a drop in IQ points. Similar trends were not seen with other AEDs. And this graph here shows the importance of folate acid. So we know folate is important to avoid, MCMs, but this data suggests here, as on the x-axis here, we have the IQ points, and as you can see, the solid lines are the patients who were on folate, and dotted lines are the patients who were not on folate. And you can see the IQ points were definitely higher for patients who were on folate. Now, the extension of the need study is the MONEED study that looks at the maternal outcome and neonatal outcome, which is gathering data at this time. So let's talk a little bit about therapeutic drug monitoring. So the most important point here is, individual target concentrations should be established before pregnancy. So if possible, we should plan ahead of time. According to the practice parameter, there was significant decrease in the concentration of AEDs seen with lamotrigine, phenytoin, levetiracetam, and oxcarbazepine. Carbamazepine did not show much change compared to the other medications. So for lamotrigine, and this is also true for oxcarbazepine, these are more prone to changes, possibly due to the fact that they are eliminated by hepatic glucuronidation, which is more sensitive to the direct effects of the rising steroid hormones during pregnancy. There was a peak of 94% increase in the clearance noted with the total, and 89% by the third trimester for lamotrigine. And seizure frequency was actually significantly found to be increased when the levels decreased to 65% of the preconceptual individualized target. Now, this is well reported for lamotrigine, but this rule can also be used for other anti-epileptic medications to a certain extent. Now, everybody is different, but this is a general rule which can be followed to guide your management. We also saw that there is genotypic variation. So not everybody is the same. So there were approximately, one study reported that 23% of the patients had minimal change in their lamotrigine levels. So, it's important to monitor carefully. And also it is important to go back to pre-pregnant doses in the postpartum phase, with maybe an additional dose to account for sleep deprivation by at least 10 days. And this is to avoid the side effects, because we are ramping up the dose during pregnancy. So we want to avoid side effects after they deliver. Similarly, levetiracetam showed levels of decrease by 40 to 62%. Carbamazepine, like I mentioned earlier, did not show much significant change, which can serve as a good option where AED blood levels are not readily available. And, as we have seen that the MCM rates are also not very high, so this can serve as a good option. And one thing which is very important is there is variance seen across women and across repeat pregnancies. So it's important to monitor blood levels in every pregnancy for these patients. Now let's talk about breastfeeding. So the NEED studies suggested that there was an increased adjusted IQ and adjusted verbal index by at least 4 points in infants who were breastfed compared to those who were not. There was a recent publication in 2020 from MONEED study group which suggested that the AED levels in blood samples of infants who were breastfed was substantially lower compared to the maternal blood concentrations. And the benefits of breastfeeding outweigh the small risk of adverse effects. One thing which we should be careful about in the postpartum phase is minimizing sleep disruption. So, if family members and friends can provide bottle feeds or pump breast milk in order to provide at least 4 to 6 hours stretch of uninterrupted sleep, that can be very beneficial to avoid seizure clusters or increased seizure frequency in the postpartum phase. So take-home points is, if possible, avoid enzyme-inducing AEDs with oral contraceptive pills. Maintain a seizure diary so that we can, determine the pattern of cataminal epilepsy and we can treat accordingly. So far, based on the data that we have, lamotrigine, levetiracetam, carbamazepine, and oxcarbazepine have the least strategic profile, and valproate is the worst. Periconceptional, and I would say even preconceptional folic acid, 0.4 to 4 milligram must be considered in all women to decrease the risk of MCNs and to improve the neurodevelopmental outcomes. Individualized target concentration should be established before pregnancy. Several polytherapy regimens are there, so not every polytherapy combination is the same, so we have to be careful about that. During pregnancy, monthly anti-epileptic drug levels must be obtained so that we can monitor them closely, and those should be adjusted for seizures, side effects, and avoid lowering of the drug level greater than 65%. And postpartum breastfeeding should be encouraged. Supplementation with bottle feeding should also be considered to avoid extreme sleep deprivation. That's it from my side. Thank you for your time, and now we'll take some questions.